Our fight against an invisible enemy has turned life in America upside down.
The U.S. now with more than 119,000 cases and more than 2,000 deaths.
I would like to begin by announcing some important developments in our war against the Chinese virus.
We now have a name for the disease, and it is COVID-19.
This is an extraordinary time. This is a character test for all of us.
We have significantly ramped up our efforts to mitigate the spread of COVID-19.
What our responsibility is and what we are doing is to put into play the kinds of things that would blunt that curve.
No one's going to go to restaurants, no one's going to go to the cinema, no one's going to go to the theaters.
It doesn't appear that any country has been completely successful at 100% containment.
We are in uncharted territory.
So it's been about 2 weeks since my last coronavirus video, and that was around the time where much of the country, including myself, started to work from home, and many cities started to shut non-essential businesses down. It would have been the Elite Eight today. Next week would have been the Final Four in Atlanta, and it would be extremely hectic. I probably wouldn't be on social media. I would be in the middle of a 12-hour shift. Instead, I am coming to you live from the comforts of my place. And I've never had this feeling as a working woman in late March where I'm actually relaxing. It's very interesting. From a work standpoint, everything's changed. A lot of things are being done via simulcast. So it's been really interesting to see the industry shift towards this new normal. How much longer this is going to go on, nobody knows. And like I said in the last episode, everybody is learning in real time. So this is part 2 of my coronavirus series with my uncle, Dr. Joseph C. Gathe Jr. We're going to keep doing these episodes as long as coronavirus remains this heavy of a pandemic, where it continues to hold society in its grasp. I'm so fortunate and blessed to have an uncle like Uncle Joe that can talk to us about coronavirus and bring in all his years of expertise as an infectious disease doctor. For me, it's definitely been a huge help just learning more and more about the virus and being more informed and more aware of the severity of the situation at hand. I think you guys will find this episode very informative, especially about testing facilities. Uncle Joe recently opened one in Houston, and he spoke to me about the trials and tribulations of testing itself and what this means for future pandemics. So take a look at this video, and I hope you guys enjoy it. All right, so we're here with Dr. Joseph Gathe Jr. Once again, thank you so much. Before we get started, I just wanted to thank you and all the healthcare workers out there that are working tirelessly to combat coronavirus.
Thank you so much. Appreciate the invitation coming back, and thanks for your thoughts and prayers. It's getting more difficult out there, and we need as much support and prayers and help in the community as we can as we continue to fight.
You've worked at a testing facility, I believe, for a week, correct?
That's correct.
So how has it been working at a testing facility in Houston?
Well, we opened one of the first and probably the largest drive-in testing center. We work from 8 to 8 daily, Monday through Friday, and it's been an amazing turnout. The wait is about 5 to 6 miles long. It can take up to 6 hours that people are coming to get the free testing that we have available. And it's been eye-opening because we're getting a percentage of people that are positive, raising the concern about the background number of people in Houston that may be infected and may be continuing to trigger not only the continuation of the epidemic, but this sort of, as people say, wave, or however you want to call it, of people that may get infected and become symptomatic in the next few weeks. And so one of the biggest things to have, though, is testing in the community so we can, one, try to predict what that wave may look like, but also make sure that those people that are positive are not spreading it to other people, and also can be connected to healthcare so we can follow them and see how they do.
So walk me through what a test normally, walk me through how a test normally goes in these testing facilities.
Well, the test we have now is we need to work on it. Right now, what the test does, it looks for the presence of the virus in your nose or your throat. And what you do is you drive in or go to a facility and they stick a swab, and it's done various ways. Some people just put it in the nose. Some people put it in the throat. Some people put it in the throat and the nose. And the reason why you have to make sure is because in order to be able to get the test done, you have to get cells from either your throat or your nose to be able to put into the container for testing. Then the test has to go back for analysis. And so the first problem with the test is that it puts the person doing the test at risk for getting the infection, because as you know, if you put the swab in somebody's back of your throat, the natural thing you do is gag and try to cough. And so we don't want to cough on the person. So the person doing the test has to have the full gear on all day doing these tests out in the 90-degree Houston heat. And so it becomes labor intensive with that. The second problem with the test is it has to go out and to be analyzed. The problem with the analysis is labor intensive because it takes certain reagents and certain time for the tech to do the test. And so the turnover time, if you will, could be very quick, but if you have thousands of samples and just a few people during the test with the reagents, it takes time to get through them all. And so that's what the basic backlog is. And so there's a big push to get more simplified testing. The problem with all that is even if you get a simplified test, we don't know how accurate the test is. For example, if you get exposed to the coronavirus infection today, when does the new test turn positive? 24 hours, 48 hours, 72 hours? We don't know because the test has never been validated, if you will. And so when we do a test like that, our concern is the accuracy of the information. And what I don't want to tell you is what we call a false negative, meaning that you actually have it, but the test said that you're negative. And I've already seen that. One of my first patients that I put into the hospital who was very sick, that we knew had all of the signs and symptoms of severe infection with the virus, but his original nasal swab when he came in that day with 103 fever and pneumonia was negative. And that swab didn't turn positive for 2 days.
Oh, wow.
And so you have to interpret these tests with a grain of salt, both the one we're doing now and even the ones we do into the future, because they haven't been what we call validated. And so it's one thing to do the test. It's another thing to figure out how to interpret it and to give you the information that you need, either as a positive person or actually a negative person. So we have to work on that. And we're doing it, unfortunately, concurrently with the epidemic. We can't do it before the epidemic. Okay, we know this test is 95% accurate or 98% accurate, or we know it turns positive within 3 days. We would love to know that, but we unfortunately don't know. But be that as it may, we still don't have enough of any of the tests, including the swab that I just told you. Our drive-through testing center is blessed by having enough swabs, but many places, hospitals don't have enough swabs to test not just patients, but healthcare workers. And so this whole testing thing, you look on TV and say, we're sending 1 million swabs out. Fantastic. Where might they be going? Because they're not coming where I am. And so there's no organized place to say, okay, we're out of them. Can you send me 50? Can you send me 100? So we're all sort of scrambling around to get any kind of test to not only, again, try to figure out who's positive or negative, but to try also to figure out the accuracy of the test. I would like to get the test, like I said, and do the test in somebody that I know that has it, because if the test is not positive and I know you have it, that test is not going to really help anybody. And so those are the things that you don't really see under the radar screen. But, you know, we're working, and I hope science is going to push forward that we'll be able to tell, hopefully sooner than later, but it's still a work in progress.
It sounds like there's so much going on, and everybody, to your point, is learning at the same time with the virus. How has that been for you? Like, have you ever been in a situation where you're like, you and your colleagues are learning as the virus progresses?
Yes, it absolutely mirrors what we didn't know in the 80s about HIV. I'm not saying the words right now is like blessing. The learning curve with HIV though was perhaps not as steep because it wasn't quite as infectious, if you will. If you understand what I'm saying, we're not looking at thousands of people getting infected on a daily basis. So I had a little time to take a deep breath and see, but it mirrors exactly that. When HIV first happened, we didn't know it was a virus. We didn't have a test. We didn't know how to treat. And we were simply learning, watching patients and trying to get an understanding about what was going on in conjunction with the scientific community and pharmaceutical companies say, look, you have to find us a test. And so we started working on the test, and HIV test took maybe a year to figure out that was the right test to do. And then once we had the test done, we had to figure out how to interpret it. So it took a bit of time. Unfortunately, with this virus, we don't have time. So we've got to do all of this stuff in the run. So I am anyway using a lot of the things that we did right and a lot of things we did wrong back to the HIV epidemic to try to speed the process up, if you will, and try to get the information out to other colleagues in the community once we figure out what makes sense and what doesn't.
Have there been any new patterns that you've noticed in the past 2 weeks with COVID-19?
Yes. One is very, very prominent and one I've seen even today. There are a group of people, and not a small percentage, whose primary presentation is not a sore throat or sniffles, but nausea and vomiting and what looks like food poisoning. And those people are looking like they're getting sicker with the virus than people that don't have those manifestations. I'll give you the story of the patient that I just saw this morning who's very sick. Who 3 weeks ago got nausea, vomiting, and diarrhea, something like you would get with food poisoning. He didn't think much of it. That was 3 weeks ago. 3 weeks ago. No other symptoms, but it was sick enough to stay home from work. It took 2 or 3 days to get over all that. But for the next week or so, he didn't feel very well. Nothing specific, just a little fever, didn't feel well. He just simply stayed at home. Now, 2 weeks after that, he is now in the hospital with severe COVID-19 pneumonia that's now attacking his heart, with no lung symptoms for that whole 2 to 3 week period of time. And so what to share with your podcast people is that one of the early manifestations of COVID-19 can be one that looks like food poisoning, nausea, vomiting, and abdominal pain. And is one that you need to at least have a discussion with your physician if you have that out of the clear blue sky. And you don't have to have any lung symptoms at the beginning of this. As I look back into the information, I was actually looking a few minutes before this podcast to say, is anybody else seeing that? And in China, they are seeing the same thing. And they quoted the first patient in the United States with COVID-19 found as initial presentation was not the lungs, but was nausea and vomiting. And so it's something to share with people that need to at least have that on the radar screen, that it could be that. But then this is back to testing. Would that test be positive 3 weeks ago when you have nausea and vomiting? I suspect not, because he wasn't having any symptoms in the head and neck. But it probably would have been positive in the stool, but we're not doing stool tests for COVID-19. So this is back to the learning curve. If we think people have it, should we be doing a test in the stool as well as in the nose? Don't know the answer to that, but we don't have any testing in the nose, much less in the stool at this point in time. So this is back to trying to learn, get the information out there. If it looks like it's going to be a problem, then we've got to go to the scientific and say, we have a problem here and we have to be able to begin to look at this. And that's important. And we're learning this almost on a daily basis.
Wow, that's quite interesting information. So who should be getting tested? Because just last week, Vice President Pence mentioned that if you don't have symptoms, don't get a test. And we're hearing from you and we're hearing from other people around the world that there just simply aren't enough tests for everybody to be tested. So who should be getting tested?
So the right answer on the board exam is, in the best of all worlds, everyone should be tested so we will know their status. The reality is there's not enough tests even for the sick people at this point in time. And so the people that I think need to be tested are ones, obviously, they have classic symptoms of COVID-19, the respiratory things, the fever. And now, as I said, people that have unexplained nausea and vomiting, you should consider to do that. Also, I think people that are intimately exposed or close exposure to people that I know that have it. For example, if I know you have it and you're living in the house with your husband and a child and your 80-year-old grandmother, I think all of those people need to be tested to make sure that they're not going to get sick. And those are the ones that I would at least start with. Once the kits become more readily available and hopefully ones that will be a little bit more accurate and easy to use, then I'm hoping we can get the test out there on a bigger scale. But now I think that is the biggest group of people that we need to target. We're working on a test that almost looks like a pregnancy test, where you do just a little blot on your skin and put it in here, and you can tell in 15 minutes whether you're positive or negative. Again, not ready for prime time, but we're moving very quickly to try to validate that and see. And that'll be a very big game changer in order to be able to tell who really has it and who doesn't.
What's also moving very quickly is a vaccine for coronavirus. It was announced that it may take 12 months of testing before it can be released to the public. Are vaccines normally done at that quick of time? And do you think that 12 months is going to give you guys enough time to get in front of the virus?
So here's my take on the vaccine. It takes a while to get a vaccine accomplished. In order to get a vaccine accomplished, the first thing you have to do is to come up with something that's safe. The second thing you have to do is come up with something that's effective. Now, how do you know a vaccine is effective? Because you can't take somebody vaccinated and just put them in the middle of people who have a bunch of COVID-19 and see if they get sick. So you just have to hope that the immunity that develops is one in which they'll be protected. And sometimes that doesn't correlate. For example, the flu vaccine that we used this year was only about 49% protected. Well, it was enough to slow down the flu maybe, but it's 49% protection if that's what we have for COVID-19 or COVID-20 or COVID-21 enough. So it's not just having the vaccine. The question is having a vaccine effective enough to stop this type of spread in the community. And the third thing, once we have a vaccine, is whether or not people will take the vaccine. The majority of people in the United States don't take the flu vaccine. You have vax-gen people says, I'm never going to take a vaccine. It doesn't take a lot of people to get a disease like this and spread it around. I think you saw it in China. It didn't take a whole bunch of people for that to go ballistic in China. And if people don't get vaccinated, if the vaccine is there, then it may not be effective in preventing the next pandemic public health emergency. And this whole issue then, I think, of having effective vaccine is complicated. The good news is you got a bunch of smart people working on it. Dr. Fauci has made this a priority. He is my go-to guy, as I said in the last podcast. And with him putting his brain in there, I think he's going to come up with something as quickly as possible that hopefully will help. It's not going to help this pandemic, but hopefully it's going to help the next one that comes behind it, especially if there's a COVID-20 or a COVID-21 or COVID-22. And so it's an important thing to push forward with, but the effectiveness, it may take longer than a year for the reasons that we just said.
What do you think will help this current pandemic? Is social distancing the only thing that's helping right now? Is that going to be the only thing that is the be all end all with this coronavirus?
So what's happening in our communities is the infection is set up shop in the cities where it's set up shop. The ones in New York and Washington, now New Orleans. And so these hotbeds, if you will, are little embers and the fire is burning. We're sitting here in Houston not exactly knowing what we're going to see because we haven't seen the explosion yet, but you can see the explosion can happen in 20 or 48 hours. And so there's nothing that's going to stop that. The only thing that we can do is to make sure that more people more people are not infected that not already are infected. So we can at least once this peaks, we can start seeing the decline in numbers of infections. So social distancing, washing hands, the things you hear over and over again, are the things we need to do to try to mitigate further spread. Once we get the testing back, it's going to help, I think. But right now, unfortunately, that's all that we can offer.
Wow. I know even here in Atlanta, it's considered one of the hot spots in America right now. And from what I've heard, the hospitals are being overwhelmed with just the sheer number of cases out here with coronavirus. Do you think we are approaching the height of the curve, or is it going to continue to spike?
I think the heights of the curves are going to be community dependent. I think New York has taken off, and it hasn't peaked yet. They said they don't know when it's going to come down. Mayor Cuomo, who is doing an excellent job with not only how he's trying to handle his epidemic there, but also how he's communicating. I'm learning a lot from him about what things maybe we can do in Houston. So his curve is going up, hopefully going to come down. The curve in Houston hasn't gone up yet that we can see. And so you don't know how quick it's going to fall till you see when it's going to rise and how quick, and what height it's going to rise to. So we're sitting around waiting. It's like sitting around waiting for a hurricane, but not knowing what category of hurricane is going to hit you, what kind of damage is going to happen. What's happening on the healthcare fields is difficult. The first thing is that we're really not ready. We don't have the beds. But the second thing is we don't have the manpower. If you look at the deaths, if you will, there's 51 doctors that have died of COVID-19 in the United States already. You've got all kinds of first responders that are becoming ill. Quite frankly, you have first responders that are concerned about coming to work because they have people in their homes that are at risk for getting COVID-19. There may be people that are immunosuppressed on chemotherapy, older people, and so they may not come to work because they think it's their best interest for their family, because I cannot guarantee when you walk away from the hospital or where you're working that you're not going to be positive. And so part of it is ventilators, but part of it is simply manpower to take care of people day to day. And it's one thing's the doctors, but it's nurses, it's people that clean the rooms for us, it's the people that take the x-rays, it's the breathing. And so we're going to get, unfortunately, depending on the numbers that we get, going to get burned out pretty quickly. And that's a real big concern because we really don't know. We don't have tests ourselves to see whether or not we are, if we're coming home, we don't feel well to get tested. And so that's also a problem. And so it's exposing the infrastructure concern of the medical system in the United States of America. And it's not just whether you have health insurance or not. None of this has anything to do with health insurance. Access to care and having care are two different things. You can have the best health insurance in the world, but if there's no test or no ventilator or no doctor or no nurse or no hospital room, it's not worth the paper it's printed on. And so I hope the wake-up call for the United States is to shine a light on the fragmented infrastructure of medicine and to say we need to invest in this system so not only this doesn't happen again, and it's going to happen again, but we're able to react to it in a strategic fashion that we know what we're going to do instead of trying to figure out what we're going to do after the epidemic has happened. And that's a very important thing that society has to answer. I can't do that. Doctors can't do that. Nurses can't do that. Society has to say, time out, we're not going to do this again. I sort of equate it to 9/11. Society said, we can't have this happen again. And so we're going to do something about it. What they've done, you got to take off all your clothes to get on an airplane now. Well, is that what we should have done? Is a hassle? I don't know if we should or shouldn't, but that's what we've done because society says we're going to do this as it doesn't happen again. Society has to do the same thing when it comes to a pandemic like this. We're not going to let this happen again. And so we're going to already have the mask in stock. We're already going to have the ventilators. We're already going to have who the second and third responders are if anything like this happens again. And society really has to wake up and make that happen because the medical system, there's not enough around left to do that.
Yeah, I think healthcare definitely has to be paramount going forward, especially with the next pandemic that could potentially hit. So in terms of being short-staffed, I think it sounds like you and the medical community are already bracing for that in the event that more and more people get infected with coronavirus, including the people that are in the healthcare industry. Is there a proactive plan that is being put in place in the event that something like that happens?
Well, what we've done in Houston, and, you know, I tell my community, you know, you can hear things on a national level, but healthcare is on a community level. We have to do what we need to do ourselves and hope we get help when we need it, but don't expect the help. So what I have worked on with a colleague of mine, Dr. Joseph Varon, and with Representative Sheila Jackson-Lee, that's been a friend of our community for years, we're opening up one of the first COVID-19 only dedicated healthcare facilities in Houston. It's going to start on Monday, and we're going to have 45 beds that's dedicated solely to the care of COVID-19 patients, to have a place for them to go, but as importantly, to gather the information of the questions that you have asked me in some organized fashion so we can report back from this community to the United States about what works and what doesn't work. Once we have that unit open, we can get the equipment that we need to make sure people are protected. So we're going to assume everybody walking in there has it. And it'll also be a call to those that want to fix this problem to come there and help us. A lot of people, a nurse may work at this hospital, that hospital, or healthcare professionals. They want to know what to do. They can come work with us for the next few months to figure out how to deal with this epidemic. And I think those are the things that we have to do. When you try to superimpose this kind of group of patients that need certain care in a system or a hospital that's not used to doing it, it's hit and miss. I may have 4 beds here and 5 beds here and 10 beds here, but it's not organized. And so our response in Houston, the community, is to work and open up this COVID-19 unit that I'm very excited about and looking forward to working with, to try to help patients, to try to answer the things that you've asked me in as short a period of time as we can, and also to try to work forward with the research. We like to be part of the vaccine research to see what works and what doesn't, or some of the medicines that are out there to see what may be beneficial or not, and also to inform the community of you know, what COVID-19 looks like in our community. It may look very much different in our community as compared to Utah or New York, or because we have different people here. It may affect us differently. It may affect blacks different than whites. It may affect HIV different than non-HIV. Those are the things that we need to know and be able to communicate back to society and the scientific community in general.
Do you think that, are you guys seeing a difference between how COVID-19 affects urban areas versus rural areas?
I can't tell yet because there hasn't been enough rural area reports. And again, things are so fragmented with information. You say, well, there's 2 cases in this county, there's 3 cases in this county, but they don't tell you who they are. You know, you have all these rules to protect people's privacy. And I have all that. I mean, I don't want to get into anybody's business, but I don't know if the Fort Bend people are all African-American or all women or all men, or men are doing worse than women. I think you've seen reports with that. I don't know if any of that is true. What I can tell you, the first 10 that I've seen so far, they're all African-American. Now, I don't know what that means. That may just be luck of the draw, or it may be that there's an issue, you know, with our community being more susceptible. I don't know, but that's the kind of thing that I want to pick up with at our unit, that everybody can come to one place and be counted. We can figure out, you know, where you fit in this equation. I mean, who's what, and come back in 2 or 3 months and say it's disproportionately affecting this group, or this group does worse, or this group does better, or it doesn't make any difference who or where you are as far as what your response is. Those are the things that we need to get back and report as soon as we can. And that's what our unit is designed to do.
Another thing that you're doing at your office is telemedicine. Talk a little bit about that.
So the one thing, you know, there's always a little bit of sunshine when there's a storm cloud. There's always an eye of a hurricane where the sun comes out. And what it's now setting us to do is this whole issue telemedicine. Just like we're doing now, you're in Atlanta, I'm sitting here in Houston. It's like, we're sitting right next to each other. So can you do the same thing in healthcare? And as I sat and looked at my practice, said, you know what? Probably we can do this. And so people don't have to take off of work and miss an afternoon and sit in my office all day. They can do it at their convenience, and we can sit and have a chat about what's going on. It really makes a difference with COVID-19, because what I don't want to do is to place my staff in the office at risk for getting COVID-19. If people are coughing and they're walking in because they're sick and coming to the front desk, then they're coughing on people before we even realize what they have. And so this allows us to screen people, to tell them, you sound like you may have something. We don't want you to come to the office. One, I don't want you to get out and infect anybody else, not just our staff, but anybody on the bus or however you get into the office. But two, I also don't want you not to get your health care. And so let's get on Skype or Zoom. Let's have a conversation. I can't examine you per se, but I sort of can with the cameras on the phone. And we can have a conversation about where you stand, what's going on with you, and where you need to go. Let's say you call me, you got 102 fever, and I'm having a conversation with you. I said, oh my, and you have nausea and vomit. Oh my God, I think it's COVID-19. Here's the testing center where you can go right now, put a mask on or put something on, or drive yourself without anybody else in the car and go to this testing center, and I'll have a report in 48 hours. Stay at home, excuse me, drink some juice, and I'm gonna call you in 48 hours about what to do next. But you call me if you get sick, or we're gonna have another interview tomorrow. And it's allowing us to bring care to the bedside or the apartment or the house of the patient, rather than them having to try to manipulate the healthcare system. It's made a tremendous difference. I'm old. I don't even know how to turn these things on, but the young people in my office just push the button and bell. Woo! The patient's there. Hey, it's all great. So it's all there. So actually, it works very well, and the patients have done well with it. I have some patients that I have a patient in Mexico. And he obviously he can't even fly here to see me if he wanted to, but we had a telemedicine interview and had a conversation. He got things what he needs. So I think this, if there's any positive raise, is going to get physicians' offices to get into this and allow people to access healthcare without necessarily having to come to the office. And so I think that's going to be a positive that comes out of all of this once we get through this epidemic.
Yeah, that sounds pretty awesome. And the fact that you're able to do that across international borders, that's excellent. In terms of the lockdown that's going on across the country, I know in the last episode we talked about how there is no overall view on a lockdown. It's been city to city, state by state. How long do you think on average a lockdown in the United States should last?
Well, I think it should last long enough as it takes for the curve of infectiousness to go down. And we have to rely on epidemiologists to say, okay, we've hit the peak, it's coming down, the numbers of infections are coming down, and therefore we can become more of a society that we're used to. But it's probably gonna come in stages. For example, let's say Houston hits its peak May 1st and it starts coming down. So middle of May, the mayor says, okay, we've hit the brunt, it's time for us to try to get back into society and get back to working. Whereas now all of a sudden everybody's going to run and do the same thing. I don't think it's probably a good idea until things really settle down for 3,000 people to go to church together until we know that it's really died down. Because the one thing we're learning from China is that now that they have reduced, if you will, the social distancing things, they're seeing the cases go up. Not so much from people in the communities, but people are coming back from where they were into the communities and bringing the infection back with them. So we're seeing spikes again. And so let's say I've got friends of mine that are stuck in India right now. So they can't come back for 3 or 4 weeks, but they're going to fly back when the lockdown is over with, and maybe they're going to come back with coronavirus back to our community. And so it has to be done in stages. I am not smart enough to tell you how you do that, but I hope smart people will be able to tell us. And I'm, again, back to my guru, Dr. Fauci. I'm going to sit on every word he says about when it's appropriate, and how to do it once that time comes.
Is there a fear in the medical community that it could spike again whenever a lockdown ends?
Yes, I think there's a big fear. And I think it's not only a fear, it's an expectation it's going to spike again. But the hope is that the spike will be not as quick and not as steep and not as, what the right word, not so much of the devastation of society, and that we'll be better prepared to deal with it. There won't be as many. We'll have a better testing system, and hopefully we'll have better medications with or without a vaccine, that when it spikes again, and it will spike again, I don't know if it's going to be COVID-19 in the fall again or something else, that we'll be able to not have that kind of peak. And so we're expecting it. How exactly it's going to look will partially depend on the type of information I can get from what this looks like. Which communities, which zip codes. There may be zip codes that have a ton of people and zip codes that don't have any. We had that with the HIV epidemic. There were certain zip codes that were horrible with HIV, and there certain zip codes that actually didn't have it at all. So all those things are going to be important as far as when we get to society back. But I do think that it will forever change the way we interact with society. You can't stop washing your hands. I mean, maybe you have to wash them 10 times a day like maybe everybody's doing now, but you got to wash them every time you leave the bathroom. You got to maybe not shake hands as much, unfortunately, that kind of thing, because it's clear that a lot of this is spread by that kind of contact. So I do think it's going to change the way that society interacts. Hopefully not for the negative, but I think we're going to be a different society when we get through this.
Switching gears to a sports standpoint, I know you're a diehard Rockets fan. I'm sure you're looking forward to the NBA playoffs whenever the NBA comes back from hiatus. From a sports standpoint, do you think that sports will come back sooner than, say, a lockdown? I know, like, even earlier today, there were some horse races on today, in spite of all the lockdowns going on across the country. Do you think sports is going to push for a quicker comeback than the rest of the country?
Yeah, I think they're going to push for it. Whether it's appropriate or not, I can't answer that. But I think once it comes back, it's probably going to come back where it's going to be a streaming video and not audience participation, because I don't see 16,000 people getting together in an arena anytime soon, even after we get out of the lockdown, for reasons that I just said, because you just don't know in that arena who's positive or negative. And you can say what you want to. When you get to the arena, you're going to be high-fiving people when Harden hits a three-pointer, or you're going to be yelling at the Texans because they traded DeAndre Hopkins, which is a whole nother discussion item that we can have. So I think they're going to come back because, society, we need something positive to come back to. I sort of equate it to 9/11. Sports sort of shut down, and then when they started coming back, it made society feel better about things. They got their mind off of what was going on, and those kind of things will help, but it's got to be done in a safe fashion. I think, like basketball, I think everybody's going to have to be tested before they go out there and play, and maybe they got to be tested, maybe for periods of time while they're playing, just to be 100% sure that everybody stays healthy. But hopefully it's going to come back. But I don't see it coming back to big arenas in the short period of time, in the next April, May, June. I just don't see it happening that quickly.
I truly believe that rallied the country together a week after September 11th with like President Bush throwing out the first pitch at the Yankees game. Like, people that weren't even Yankees fans all of a sudden wanted to be a Yankees fan. And that's still a very pivotal moment 20 years later. How long do you think it'll be before, because you just said that the summer might not be an ideal time for fans to be back in the stadiums. Would it be something like the end of the year or next year?
Well, I think it's going to be before that, but it may be, for example, that the Yankees can't play in New York because the epidemic's so bad there, but maybe they can play in Omaha, Nebraska, or somewhere where the epidemic just hasn't hit, or the numbers are so low it becomes inconsequential. So I think it's going to be something along that line. It's going to be played in areas that are whatever the definition of a low risk is. I don't see anybody playing any time in New York with the type of numbers that they have, because you just can't put 10,000 people together anytime soon in that community till that dies down, whatever it's going to be. But, you know, I can see the Yankees playing in Logan, Utah, or, you know, wherever the numbers aren't high, and maybe even to, you know, groups or crowds in those areas. I think we're going to be playing at more neutral sites to try to get the sports back on, and hope it's going to be the early part of the summer. I don't know what the NBA is going to do, because, you know, the NBA says one thing, baseball and football sort of start then. What do you do about basketball? You know, because even if you start right at the playoffs, it's still how long is playoff? A couple of months to get through all of the playoffs?
Yeah, 2 months.
Yeah, so a couple of months. And so they'd have to almost start, even if you started in June, you know, it's almost next season before. So it's something they're going to have to work on, but I suspect it's going to be done where sites where there's much more below risk of spread. But I think those are the kind of feel-good things, and the balance, if we can make it happen, I think it's going to make us feel better as a society. It's one thing, sports brings us all together.
Yeah, definitely. And I mean, you know, working in the sport industry and working for NBA TV and NBA on TNC, I know like everybody is excited to get back to a sense of normality. And to your point, like with the NBA playoffs, June is finals time. Like June is usually that last big push for us. And then you start focusing on this next season in October. And I think that's going to be something interesting, especially for me to follow, is, you know, as these seasons start running together, you know, what is that period between the end of one season and the start of another? It kind of reminds me of like one of my favorite shows in high school was The Legend of Korra. And I remember season 3 ended 2 weeks before season 4 started. And right. I mean, like the politics behind that is a different story, but it's just like you didn't have time to like digest and breathe and reflect upon what you just watched before the next season started. And athletes might not have enough time to recover before that next season starts. It's like, man, I just won the finals. We just celebrated the parade, you know, whether we're going down like Westheimer or Biscayne Boulevard, like I just celebrated. Now I have to get back into a mode that I'm not used to.
And then the question comes, you change the rules. I've heard something about baseball playing 7-inning game doubleheaders to catch up. I mean, that's one thing I saw. I don't know if you've seen that, but I saw somebody somewhere posting that. And so do you really want to change the rules of the game to get in? And, you know, me as a sports fan, I want to see my real sports. I mean, bring it back when the sport is, you know, I want to see give me 9 innings and, you know, the whole 9 yards with that. So it's all of that about, you know, how you're going to balance all that out. So, but I'm sure that the sports franchise are going to be organized and ready to go. And I'm sure Fauci's going to be the guy that's going to lead and tell us when and where to do it. And hope it's going to be sooner than later.
Yeah, I hope so too. And, you know, speaking of baseball, I hope the Astros get their act together. I'm still very disappointed that they.
It's not a good time to be a Houston, between the Astros and the garbage pails and DeAndre Hopkins taking his dreadlocks to Phoenix. It's not, and then you Rockets and small ball, and is that going to work? It's rough being a Houston fan right now, but you know, there's always hope. There's always hope.
It is. I mean, you know, I switched my basketball teams years ago. So, I mean, if you ever want to be a Miami Heat fan, by all means, come and join the band. Yeah, we got a DJ, and we have, you know, South Beach, gorgeous weather. I mean, it's fun.
Sign me up. I may have to go to that side of things.
Last question for you, to end it on a fun note. I don't know if you've heard about Club Quarantine with DJ D Nice on Instagram. Have you participated at Club Quarantine?
Club Quarantine. Hook me up with whatever that is. No. What is it?
So Club Quarantine, there's a DJ, he's a New York native, his name is D Nice, and you know, he's been DJing for decades, and basically he decided to get on Instagram and have a party because, you know, we can't go to the club anymore. So he decided to have this thing called Club Quarantine where he just streams a DJ set for 3 hours. And it's cool because Instagram Live is so interactive. So all these people join the chat, and they start putting like hand emojis in the air, and celebrities walk through, like President Obama, Michelle Obama. Halle Berry requested Prince. He did a whole Prince set to close out one of the nights.
Oh, cool.
Yeah.
That's really cool. All right. Let me get my afro back and get back to my young man. If I can't get to club quarantine, sign me up.
Right, like Dr. J's in full effect.
There you go.
And last night he took over NBA's Instagram and did a 3-hour set. But it's cool, like he does old school music from the 70s all the way up. And it's a lot of fun, and it's cool because like everybody gets to interact, even though we're all like solo in our own places.
Right. I'm looking it up and playing old school music, and I can understand the words. I'm near. I'm near.
All right.
Boy.
Well,
All
Dr.
right.
Gathe, thank you so much for joining me on this conference call. I really appreciate your insight. And once again, thank you. And thank you and thank all of the medical professionals that are out there, still working overtime just to, find a solution to this coronavirus and get as many people as tested and quarantined as possible.
I'm on it. Thanks so much. And let's do it again soon when I have some more information, hopefully in the not too distant future.
All right, let's do it.
All right. Take care. Be safe.
All right. Same to you.
All right. Bye-bye.
For more on coronavirus and infectious disease medicine, please visit the links below. Stay safe, everyone.